So I'm going to give you a few minutes to recover. I'm just going to start with the opening. It's the Bladder Basics. So I'm going to try to focus mostly in the stress urinary incontinence and urge incontinence. Otherwise, it's a specialty by itself. One of the reasons that incontinence is relatively common, it's across the multi-specialties. Us as primary care physicians and most of the OBGYN have, reasonable input into the treatment, diagnosis and treatment. Just have to tell you, including OBGYN, and treatment of urinary incontinence has changed a lot. It's becoming more and more a subspecialty, both because of the treatments, which a lot of them are surgical for stress urinary incontinence, and the medical treatment probably for the urge incontinence and overactive bladder. That's something probably we're going to see a significant input from our perspective. Including me, I was just doing a lot of, stress urinary incontinence procedures. Started the debacle with the meshes and everything else, so the FDA got involved, and just suddenly things are starting to kind of narrow down who's doing what. So it's an interesting change for us OBGYN perspective. How many people are OBGYN that still do stress urinary incontinence procedures here? You still do them? Okay. So I start doing them. I send them to the urogynecologist right now, which is very interesting. Even though I'm relatively high volume gynecological surgery, it's interesting how people subspecialize in everything. So no disclosures. So some facts about the urological condition in women. So it's a significant problem. I mean, this is something that transcends, from the entire specialties. You don't have this 53% that have UTIs. It's, young women, 18 to 44, that have urinary incontinence, 25%. We're looking, 3 million people looking, an IC. 5% they might have a kidney stone. Renal cancer. You have recurrent UTIs. It's across, every racial group. So one of the issues is this is, the bladder, is such a small, organ at the end, creates a lot of the issues. The background regarding the urinary incontinence right now, I'm going to try to focus on this extremely large pathology and for bladder and for urological disease in women. But what I'm trying to do is, discussed before, 25% in young women, 50% in middle-aged women, and goes to up to 75% in older women. So you have, simple, 25, 50, 75. So it just goes up with age. Depending on your patient population you treat, especially a primary care physician or internal medicine, you may see this a lot. It's the likelihood that you're going to have a patient walking in your 70s that has 75% chance that has a disease, which we like to screen or ask for if the patient doesn't come to you. And that's one of the problems. Many women do not seek care. As an OBGYN, I'm always just thinking, should I ask the question or should I not ask the question? Because it's just changing from an annual visit to an evaluation. And I have to tell you, I feel guilty. So what do you treat? You treat the one that complain. We treat the one that you're going to do a physical examination and we see that what's going on with this rash here, and you're going to ask more questions at that time. And it's sad. But urinary incontinence, it's not a normal. It's not something normal in a postmenopausal or in any woman for that matter. So we have to ask the question. So just be aware when you're going to do your annual examination, kind of plan it out for this type of, and see where you go. You can build a practice based on this if you want to do it. So you have to see, but at the same time, we shouldn't particularly ignore it. Well, it's a problem. It affects everything. Physical, functional, psychological limitation, obviously quality of life. It can affect the sexual function. You have other medical problems. And I have to tell you also, it's become a problem for the family and the caregiver burden. So a little bit of anatomy, just for us to know what we're talking about. Talk about the trusser, talk about the internal urethral sphincter, talk about parasympathetic input that excites the detrusor muscle, and talk about sympathetic input that excite the internal urethral sphincter. So gonna give us an idea, what we're talking, about. We're talking about the pelvic floor and external urethral orifice. If it's a surgical, more surgical approach, you have to obviously know your anatomy, but the rest even to kind of understand the treatment rather than for us to kind of understand some management, or going to give this pill and see how you respond. So this is where it comes from. Etiology, and these are like very simple slides, just because it's just way too much for us to go through all of it. But I look at the genitourinary, type, and we're looking for non-genitourinary type. I have to tell you, my main problem is when we have this patient population come in, it's older population. This is my main problem, which is the CNS disease. First of all, it's a little bit harder for us as an OBGYN. We're dealing with 50% obstetrics, 50% GYN for us to do a very good physical neurological examination. So you have to rely on your primary care colleagues to help you or through neurological evaluation. I think obviously you have to kind of think about the CNS disease, especially when you have an acute event, especially in older population. Because there are a couple of things. If you have a problem, a sudden urinary incontinence, make sure you're not missing the CNS disease. Some people say, well, you can have a UTI, that's fine, comes to your office, you check a UNCNS, CNS, look for other things, look for blood in the urine, but also do not forget the possibility of a CNS disease. Types of urinary incontinence. So, we have a large box here, and basically, we're gonna try to focus the one that we're gonna deal the most. And we're looking for the, stress urinary incontinence and overactive bladder. So you have to understand, the urgency urinary incontinence kind of comes together with overactive bladder. Overactive bladder is, it's urinary urgency, you have frequency and nocturia, and a plus minus associated, urinary incontinence. Stress urinary incontinence is mostly related to the involuntary loss of the urine when you do physical activity, and we know coughing, sneezing, jumping. The rest, you have to be a little bit careful. There are a lot of them that even as an OB/GYN, we don't see them so often. Doesn't mean that you have to ignore them. But the focus is for us to see these two large components, or actually the three large components: the stress, the urge, which includes a little bit the overactive bladder setup, if you don't go to the incontinence setup, and overflow. And overflow, it's interesting. Overflow is, you always think, oh, listen, if something gets blocked, you can have a CNS disease. But also you can have a desensitization of the detrusor muscle wall that we discussed. And that comes actually with atrophy and age. So you might have some overflow incontinence, not necessarily because you have a urethral blockage. You can have, CNS disease, and sometimes you have just basically atrophy related to menopause. And sometimes even just infection that can happen. What do we do? Evaluation. And the evaluation is, obviously you ask questions. And this is what it comes into, is what you want your visit to be through, because otherwise you can get a little bit lost. And there, you can ask about the frequency, you can ask the fluid intake, the precipitating events. You can make it very short or you can make it very long. But the most important is for us, so listen, if I don't ask key questions that I know how to find out if they have, and somehow what type they have, and just kind of quickly go is stress, is urge, is mixed, is the mixed with a little more urge, is a little bit mixed with more stress, because kind of that defines where you're gonna go with your treatment. You can ask all these questionnaires. They're validated questionnaires. You have the urogenital distress inventory. You can have questionnaires regarding the bothersomeness, the distress to the patient, and also the effectiveness of your treatment. So there are just multiple of them. We use a lot of them into the trials. Some of them are very long. I have to tell you, it's just unlikely going to have this patient with some gait issue completing 20 questionnaires with multiple. It's just difficult. But there are some of them short ones. One is three questions that you'll be able to, and actually can differentiate very easily between mixed stress urinary incontinence and this. So that's something that I'll suggest to you. This is 6 questions, and it's very easy to complete, and just be aware of that. If you need this questionnaire, so listen, where am I going to find them? Just go to AUGS website. I mean, they're just pretty good. The resources, you guys are familiar with this website? Just the reason I put it here is just actually, It's urogynecology, 101. It's very easy for you. You can print out, go to resources. I should have actually do a drop down, go to resources, and you have printout with pictures and everything else that you can put it, the patient can read it before. So use it, use it, use it. I'm not a urogynecologist, but this is an excellent website, Voices for PDF AEGS website. Go on the resources and you're gonna have everything from training Kegel to explain to the patient what a cystoscopy is. I just really strongly encourage you to go. They give you even your intake and voiding diary because it's part of your evaluation, which is looking and because it's important for you to evaluate. It has to say, when does it happen? What is the problem with the bladder? So you can get a little bit confused, and now with the documentations and everything with the EMR, if you don't have built it in, it's a little bit harder. Then you can print it out, and you can scan it, and you have it. So it's important for us, Voices for PFD. So part of the initial evaluation is obviously, the medical history. Remember the medical comorbidities. Obviously diabetes, but neurological disease, stroke, lumbar disc disease. This is something that as an OB/GYN, we're more careful about it. We just do not know how to manage. This is something that we're looking, for the primary care physician to work with us. Obviously, if you have a history of incontinence, anal incontinence, we have a history of constipation. They're just two separate issues. But constipation makes you push a lot. Anal incontinence is going to tell you may have something with the entire pelvic floor or with some nerve injury that you should be aware of. OB/GYNs are a little bit better as to getting the history, but obstetrical gynecological surgeons one. But actually obstetric, not only the trauma, but even the sizes of the babies. Obviously, the larger babies tend to have more, pelvic floor trauma, and increase the chances of you having incontinence. And the other one, the medication. It's a long list of medication that can create, urinary incontinence. And the magic, caffeine and alcohol. Easy. What do you do first? Just make sure you don't have a urinary infection. And just make sure you don't have blood in the urine, because that kind of changes where you are. So that's very simple. You can send it for UNCNS, you can do a quick dip, and that's something that everybody should do, people that complain. You don't want to miss a urinary tract infection. You do not want to miss, bladder cancer, which is relatively, it's 8th most common cancer in women. I even didn't know. It's very interesting. No, the renal is, I'm sorry. So you don't want to miss that. It's interesting that that's something that came out with nocturia versus polyuria versus just plain nocturia. So one of those with the urge, you're going to have a little bit more people getting up at night, and that's more of was associated. Well, the guys go at night because of the prostate issue, and I'm not particularly an expert into that. But you have to, when you ask this question, this is the word voiding diary, it's important. One of the medical problems that we actually tend to ignore on comorbidity is, obstructive airway. So, or, sleep apnea. So it's a very interesting, and this is not something new, it's in 2006. So you can actually get better with your urinary incontinence by using a CPAP. I mean, this is, where are we coming this from? And one of the issues, so just treat the sleep apnea with a CPAP and you improve the nocturia. I mean, it's a little bit harder. I don't think it's only the CPAP. I think, a lot of that is associated with obesity and other comorbidities. That's the only thing. I'm going to put this patient with a BMI at 25 and the likelihood to have in, your 30s to have a obstructive, to have sleep apnea is probably less likely. But just do not forget, if you have symptoms of nocturia, just ask about, possibility to have the sleep apnea as part of your evaluation. I started to ask more about that. Physical exam. So it's important, and the reason is we're looking for, you need to do a physical exam, independent if you have stress, mixed, or overactive bladder. You just make sure that we saw that long box of, of what potential things. Of course, you don't want to miss a fistula. Diverticulum might be able to see. Look for other, signs of, menopause and atrophy. You look for signs of infection. Look for prolapse, of course. You do your examination. You can do a neurological examination, you're pretty good. And actually, you always like to kind of see, well, these are our S's, S5, S4, S3, S2, and then go back on L's. Actually, probably the most important thing it's here is the cough stress test or the bladder stress test, though it depends how you do. Because at the end, this is the way you're gonna diagnose the, stress urinary incontinence. And not necessarily, we'll discuss a little bit about urodynamics a little bit later. So what do? You just bring the patient to the office, you don't have their complaints, and you did your evaluation, initially. You may do a voiding diary, and the patient with the bladder moderately full, comfortable full, you're gonna have them standing, you just spread the labia and just ask them to cough, and you're gonna see actually, leaking. And said, no, it can happen. Well, what are we gonna do with an older population that might not so easily gonna stay straight, put your fingers and just ask them to cough? Then, well, they're gonna put them in supine position. But I have to tell you that you're gonna have this patient that, and they have stress urinary incontinence when you do their pap smear. You put, even before examining the patient, they just, put them supine, they start coughing a little bit and you see the leaking. So it's the most important test from examination. So listen, I'm a primary care physician. I do not know I want to do that, but it's easy. You don't have to do a full pelvic examination. Then put them to straight. We do a lot of examination. Just spread the labia and help them to cough. I mean, this is kind of straightforward in an examination, especially they complain to you. Urethral mobility, we can do the Q-tip. That's becoming a little more involved. I think we're going to see in stress urinary incontinence, see this hypermobility of the urethra. Post-void residual, well, post-void residual implies, that you have to have technology in the office and, cost associated with that. So this is what it comes. What do you want to do? Do I want to build a practice around the bladder, or do I just want to be a referral? So the post-void residual is not necessarily part of the evaluation. But, cough stress test can be done. Pelvic exam can be done. Even the Q-tip, if you really want to go into it, even though it's a little more invasive, you can do it. But I think this remains the most important cough stress test. I'm going to tell you stress urinary incontinence. Well, what about urodynamic testing? Well, it's the multi-channel, it's kind of very complex. I see a lot of lines and changes, So becomes an issue. I mean, obviously it's a tremendous investment. This is done by urogynecologists or urologists, depends who is in your area doing this type of information. It's much simpler than it looks to do. We measure all this, vaginal pressure, bladder pressure, urethral pressure, and we do a cystometry, uroflow, we measure, the urethral pressure profile, Valsalva, leak points, and everything else. So it's a complex measurement. It's a complex measurement, takes time, takes investment, and it's expensive. So when do we do that? So like, should we do on everybody? Well, the indication for urodynamics actually is not for the, part of the initial evaluation for stress urinary incontinence. The cough stress test or the bladder stress test, however you want to call it, that should be your, your evaluation. So it doesn't mean you cannot assess for the stress urinary incontinence in the primary care, settings if you don't have a urodynamics. So when do we do urodynamics? Well, it's very clear. So, well, we do not know what's going on. Then you have symptoms of stress urinary incontinence, based on the history, but you cannot elicit your bladder stress test. And you have to see this. So, well, how good is your cough stress test? It's a sensitivity up to, 75 to 97. I mean, we just basically see it. Yeah, can be some issues. Can be some issue that your bladder might not be full, so be aware of that with the patient. Or the other one, when I ask people to do something, they just get inhibited. But it's a pretty good. If also, and this is something that you might, try to do your stress, your cough stress test and doesn't work, but the patient said, I cough and sneeze, yes, the urodynamics is indicated. If you treated already the patient and doesn't get better, and definitely if you have a previous surgeries or other type of pelvic floor surgery, you probably have to go to your dynamics. But this is your change from sending these people to urogynecologist. This is our treatment, or to urologist that does female pelvic surgery or treatment. So this is what you're saying, but I know all the urogynes that do it all the time. You walk in, you get urodynamics, $700, $1,200 reimbursement, everybody gets it before. Well, this is a urodynamic testing trial in a New England journal. So it's not necessary for uncomplicated ECI. It does not affect the outcome compared with office evaluation. So you have a New England paper that backs you up. So for women that this preoperative evaluation alone was not inferior, because the inferiority type of to evaluation with the urodynamic testing outcomes of 1 year. So someone tells you that your exam is not good, I mean, that's the two separate issues, but you have a paper that tells you you do not need to do urodynamic for stress urine demonstrable. Because this is the question. If you see it on your exam, you can go for the next step. You don't need to do urodynamics. So once more, when the urodynamics is needed, this was demonstrable. So unable to demonstrate SUI on examination while the patient has this complaint. So these are like kind of a trickier ones. But I have to tell you, with an SUI being so common, you just have to kind of divide pretty quickly in your office the way I'm looking at. This one demonstrable, be able for us to go this way. This one is not my required testing, rather than for you to find each individual patient and say, well, let me kind of find out towards the end. We have to do, what do we do, population health right now? You have to do kind of everything, kind of protocol and everything, check boxes. So you have to kind of move fast. If you have some kind of urgent incontinence, if this patient comes to you, put some medication and do not get better, of course, that's the other thing. Make sure that you try one, you try twice, you keep it 6 weeks, 10 weeks, we'll discuss a little bit, later. Maybe it's the time for a urodynamics. So this is what you're gonna have to learn what you want to do in your office. You're gonna be mostly, evaluation, screening, evaluation, and then kind of a, treatment for the urge. And maybe a little stress urinary incontinence, because not every stress urinary incontinence needs to have surgery. Cystoscopy, yes, you can. It's office-based, kind of straightforward, but you do not routine. It is not routine indicated for incontinence. Obviously, if you have recurrent UTI, if you suspect fistulas, if you have you put a TVT before, you don't know what it is. If you see hematuria, that's part of evaluation of the cystoscopy. Pretty straightforward office-based procedure. So now we go back to treatment. So listen, I'm not a surgeon. So what am I do? So the stress urinary incontinence, half of the incontinence, I cannot be able to treat. Well, it's not like that. You can. You can do, weight loss. So it's interesting enough. You can do bladder training. You can do for stress, incontinence, including, urges. You can do actually exercises, the Kegel exercises. So it's interesting with, weight loss. The weight loss, it's an issue. It's not easy to fix. Weight loss for diabetes, weight loss for high blood pressure, weight loss for cholesterol, weight loss for a lot. But if it'd be so easy, people would do it. It's not so easy to lose weight. And that's something that we have to keep that in mind. But what I want to say is, this is another New England. And New England likes the incontinence, obviously. They have these papers all the time. The PRIDE study, even with moderate decrease in the BMI by 8%, you have a decrease in urine incontinence. And that's combination of both. So you improve both stress symptoms, you're going to improve urge symptoms, and obviously definitely. You have decreased by urinary symptoms by 50%. So interestingly enough, you see this is kind of mixed both urge type of incontinence and the other one is stress. But a high reduction for stress urinary episodes. So listen, I cannot treat stress urinary incontinence in my practice. Well, if you have a decrease by 8% in the BMI in this patient population, you decrease more than 50%. I think this came back as 60-something percent, just the stress urinary incontinence by themselves. So what was the issue? Was the 6 months, just with the behavior intervention. So the bottom line is you really need to follow up on this patient. Obviously you put the weight back, it's not necessary, which is very easy to do. You might lose this result. What about pelvic floor exercises? So I don't do surgeries, but what else I can do? Well, you just do pelvic floor exercises. And this was a large one, I think a few good years ago, 2014, 4 years ago, they have this, review in the Cochrane Library. And basically, they're looking at pelvic floor, muscle therapy, pelvic floor exercises, Kegel, and there's just different variation what you can do. It's the first line of conservative management. So don't think you have to send everybody to surgery for stretching. You have to start with the conservative management. You can do the weight loss, you can do your CPAP, you can do your bladder training if they have more of an urge. You can do your physical floor therapy. You can just do plain Kegel exercises. You don't have to necessarily send them to a PT. And the issue is, I understand, but it's like going to the gym. There's some people that go and they're going to go forever. There's people that are going to go in January and then they stop in February, and it's a little bit harder to follow up. I'm not even category. I don't go to the gym at all. So for me, it's. But I understand the issue. Can you go repetitively and do it? So at the end, look, what the patient population is that's going to benefit out of it. So the bottom line is the success rate for pelvic floor exercise is not bad. You're going to get around 50% success. This is an older kind of a standard trial, but they're looking at some predictor of failure. So it's interesting. If you have kind of 2 or more episodes per day, if you really leak at the first count, well, definitely it's an interesting thing, psychotropic medication. I don't know how many there were in this patient population on the trial, but definitely it's one of the predictors. You have to take a look what you expect for pelvic floor. So these are the patients that you still need to do it, you put them to do it, but just have to kind of keep in mind, this is going to fail. Let me kind of, refer this patient out to people that potentially do surgery. So yeah, you start, but then say, oh my God, I fix you, it's 50%, and watch out for a subset of patient population that these are predictor of failure. So the bottom line, the worse it is, the less likely that even if you do, even though they go forever with, stress urinary incontinence exercises, pelvic floor exercises, they might not work. Long term, they follow people up to 15 years. This actually was just 50, 60 patients. It wasn't a small study. So they put the patient in an intensive group under physical therapist, physician, and they send them a home group. So obviously, if someone is watching what you're doing, like a homework for the kids, well, if the teacher watches, you're probably going to do 60% of the time. If you go home and the parents are not home, that's your success rate of long-term outcomes. So it's interesting. It doesn't matter if you study. It is initially they watched them for 3 months. At the end, everybody started not to do it anymore. And also it was an interesting kind of, didn't matter if you did a long-term, the percentage of going surgery, and so obviously it's a lot of data is, for stress urinary incontinence in both groups is the same. So it was a little bit kind of a concern. So, well, you cannot basically keep this patient forever on exercises. Some form of other intervention is going to come up. And this is what you have to think. You want to plan it out. They might plan out for patient population that might get sicker, patient population that might get older. So you have to see if you have success with therapy that is non-invasive is perfect. But if you see those predictor factors, that's kind of worst type of incontinence. If you see this patient is going to get surgery anyway, maybe we should start with surgery sooner. So this is where New England came back, said, whoa. So for stress urinary incontinence, they try to divide in physical therapy and all this non-invasive pelvic floor therapy. You have subjective improvement, but be careful. It's not mild. It's moderate to severe stress urinary incontinence. You have 90% improvement in surgery and around 60%. That's not bad. I mean, discuss around 50% is success rate. In this particular group, around 60%. But we'll see 90%. This is actually ended up being statistically significant. And what did they say is, this was a kind of a larger Dutch trial, said once more is moderate to severe, so initial mid-urethral sling, the MUS, compared with initial physiotherapy, higher subjective improvement, and actually even objective cure in 1 year. So You cannot just say, I'm going to keep this patient here forever, and don't say, well, the sling doesn't exist, something is bad. It's really good. You just have to see how you're going to approach this urinary incontinence in your practice. So don't let this patient population, they have a pretty good success rate, but definitely it's everything, all this number is 1 year though. Pelvic floor, remember in OB, everything is 3, do 3 sets, relax 3 seconds, and do it 3 times a day. You can actually go and just have them printed out from the PFD, from AUGS website. It's just such a good website for if you want to do just basically intake and evaluation of this patient. Try to see if it can do it. Works. The problem is, works initially, the patient, do not come back. They just don't do it. Beyond, a few months or so, I noticed, even though there's improvement initially, we're just going to see a slow decline into being compliant to their Kegel exercises. So then what you're going to do is say, well, you know what, I don't do surgery. Well, you can use one of these pessaries. It sounds a little bit kind of frightening to me. I just don't do too many pessaries. I don't know, I have to come back and fix. It's just, actually it's very easy. And there's something that depends where you're located and how your patient population is and what access you have to more subspecialists. And also the pessary, if the patient can take it out and just replace it and clean it herself, it's fine. But then you're gonna go into the situation, should I bring this patient every 3 to 4 months for us to do the cleaning? But this is actually, it's an excellent option. What's the problem? Obviously the patient is sexually active and everything else changes a little bit the dynamic. But it's not something that you have to throw out. It's easy to do. It's not as scary. We do not like to clean them when they come in the office. Tend to be a kind of a longer visit. Make sure when you put them in, you just do pelvic examination, look for erosion. Watch out for the postmenopausal patient. Can get that they may have some laceration. If they do, use some estrogen cream. Make sure you don't develop postmenopausal bleeding. Sometimes, what I noticed, the more you use the pessary, suddenly people have postmenopausal bleeding and have to do the workup of postmenopausal bleeding. So just be aware of that. But there's something that can be done. Is non-surgical, reasonable success, and they're looking at, this is the Atlas trial at 3 months, and they're looking here, well, compare, the physical therapy and behavior therapy with the pessary. In a pessary group, we're talking about a 33% improvement. Behavior group, 50% improvement. So, wow, this is better. So you can do the exercise. Of course, it's better than the exercise. The problem when I look at 12 months, it's kind of went back to the same. So the issue comes, why? Because it's just people in the behavior. The pessary stays there, and if you do the cleaning, gonna get your success rate. In the behavior group and all this pelvic floor therapy, they start not to do it, especially if they do it alone on their own. I mean, obviously people try to do it combination therapy, interestingly enough, was not superior if you do combination therapy separate, between the pessary and the behavior group. So that's something to know. So remember, we have, now go to surgical treatment, and we're gonna run pretty quickly. I think the most important that, we'll try to do is just to kind of, the mid-urethral sling is the standard of care for, stress urinary incontinence. So when you have this type of procedure, you have, the synthetic, you can still use the suburethral fascial sling for more complicated. And even more complicated is, this Birch-Colpo suspension, especially if it's associated with other type of procedure. So it's a controversy between the synthetic and for vaginal, for the prolapse, but there's no controversy regarding the mid. So make sure we differentiate. We don't use meshes anymore. Yeah, it's true, a mesh, but you call it a sling or a mid-urethral synthetic mesh sling. So this, we can still use it. And actually, there are variation of them. The most commonly used is the retropubic approach versus transobturator approach. Which one do you do? What do you do? Both. Both? Why? Why do you do both? Most of people pick one that works for them.
I usually do the TOT.
The TOT. Yeah, for the ISD or the okay. So they're comparables. subjective rates, it's between 71 for retropubic, 98 for transobturator. Complications probably similar. Do not differ, around 2%. Do not differ between two approaches. The retropubic might give you a little more dysfunction. So the bottom line, you may switch the stress urinary incontinence for some kind of urge incontinence. Just be aware of that when you put this. Obviously, you can have major bladder perforation. I think we got a little bit better with it. Major injury, unlikely with the blood loss, and vessel injury is small. The transobturator, it give you a little bit more of a growing pain. The mini sling, the size is just one, and the different company, they're top to bottom, outside, inside, and they have all these geographical and geometrical approaches. The mini sling said, wow, that doesn't sound so threatening. It's smaller, the no skin incision. The problem is the lower subjective and objective cure rates. It's higher rates of reoperation. So when you put a mini sling, just keep in mind that basically it might come back, it might not work as well. So it's mini from the perspective not length, but also from the perspective the outcome. Obviously, this gets a little bit suburethral fascial sling. This is a more severe disease, or you're going to have a complication with the previous measure. This is kind of a little bit beyond of our discussion here. I just wanted to, that they're just different. You have the mid-urethral and you have the suburethral. Bulking agents. So bulking agents it's an interesting thing. Actually, it works very well. It's an office base, which is great. It's very important for the patient that it's not terrible, such a good candidate. But there's some issues. It's less effective, and you have to make sure to counsel the patient. I know that this is a referral. The point of the slide you may want to think about is, oh my God, I have such an old population, doesn't move, that's not the best surgical candidate, but have this, she coughs, and she has all these rashes on the perineum, and how I'm gonna address this is recurrent, I treat. So there's maybe some bulking agents. So bulking agents is fine, can be transurethral or periurethral. Couple of issues, you have to do sometimes repeat injection. And be aware of a 10% chance of self-catheterization. So I don't think we don't do it in our office. Even urogynecologist has a little bit of an issue with them. But that's something for you to know, that at least to be aware of that opportunity. Birch. Yes, the birch, we're going to have it done laparoscopic, robotic. Everything is done, robotically nowadays. But generally speaking, if you do a mid-urethral sling, it's a little bit prefer birch. Probably the only time that you have some apical prolapse. In that case, probably you should do a birch. Just on the list, I haven't done birches in a long time. Couple of things about the surgical treatment. He said this is one of the problems. It's not only just a plain TVT or TOT. It's also coexist with the other type of pelvic floor and a pelvic organ prolapse. So usually end up doing procedures for both. Otherwise, you can learn to do it. This is probably one of the issues that I started not to do, and to refer them to urogynecologists altogether. Because most of the times it's not only a mini sling, where actually you can put it, but you do wrong to the patient. Once you're going to start putting mesh in the vagina and try to kind of redo the surgery, it's always harder. It's not only the complication risk associated with the meshes, with the slings, but it's also if you miss the pelvic organ prolapse or you don't do it, you have the surgery is harder. And I'm telling you, going to those planes is just never fun if you already have. Then the other thing what happened is, well, you don't elicit too much of a stress incontinence, but you have the prolapse. And then it's the other way around. You fix the prolapse, but then you have this so-called stress urinary incontinence. And then you might see in your office, go to, usually urogynecologists are pretty smart about this, and they do part of the evaluation, make sure you don't miss it. But because it's quite a large number, you don't want to do your pelvic organ prolapse type of surgery and then find out that, oh, I should have put a sling also. So this is, SUFU's evaluation. So this is going to put it all together. So remember, for stress urinary incontinence, do your history, do your physical exam, and part of the physical exam demonstrate the stress urinary incontinence. Do your cough stress test, your bladder test. That's enough. You don't necessarily, you do a UNCS, you might do a PVR. You don't necessarily have to do a cystoscopy. And if the stress urinary incontinence is clearly demonstrated, you don't need to do urodynamics. So a lot of these things, in a regular practice you can do, especially if you want to focus on the bladder. Not everybody needs to get surgery. So this is what we're going to get the piece of it. It's not a non-surgical treatment. I even won't talk too much about surgical treatment. You can put pessaries. Yeah, you can do some vaginal insert. You can do your pelvic floor exercise or behavior therapy. So you have options for this patient initially. I mean, obviously, we're looking at the success rate, and the issue is, don't forget that still a sling, someone that has demonstrable stress urinary incontinence is still probably a reasonable option. But if you don't have opportunity, the patient doesn't want to go through surgery, you have options. Now we're going to move a little bit to overactive bladder urge, and the same thing, SUFU has these guidelines. And a lot of them we discuss about evaluation. You're going to do the evaluation, you're going to see this patient anyway, you're going to do your voiding diary, you're going to give them this, your favorite validated questionnaire, and just use it constantly. And the same thing is, the difference is just make sure the patient desires treatment and is willing to engage, into this. And the standard therapy is becoming, they have a little change. I think it was 2012, and then they came back in 2015 with guidelines, So behavior therapy is, it's a standard right now. And then after behavior therapy, add pharmacological management as a standard therapy. So for the, urge, or overactive bladder, it's a little bit different. You do the behavior therapy, you do pharmacological therapy. One thing I have to think about is we do not have too many options. So this is what I'm telling patients. We have to find an option here, because it's not going to do a surgery, it's going to fix everything. At least, when you do a Kegel exercise, people, for the stress urinary incontinence, they're going to put a sling, they're going to fix it. But for the urge and overactive bladder, there's no particular surgery that's going to work very well. So, so this is behavior, patient education, like always. Behavior therapy is, standard pharmacological. So this was a little bit of a change. They put a behavior therapy a little bit earlier. Was behavior, fluid management. Obviously, watch out what you drink. You don't drink too much. Don't drink too little. You can decrease your caffeine, your intake, and it's a long list if you go to that AUGS website with foods and everything that the patient should avoid if it's possible. Pelvic floor works for both. Remember we discussed, he said, well, the Kegels is more for stress. It's true, but they improve also the urge incontinence. And actually, the Kegels, it's better than placebo for all type of incontinence, but obviously it works a little bit better from SOI. So you might have someone with urge, so I'm going to give you a medication. Well, start with the behavior therapy a little bit with dietary changes. Put them to do some Kegels. So that's something that I want to kind of keep in mind. You can use the Kegel with bladder training, by feedback and electrical stimulation. So here becomes a little bit tricky, because really, or you have a urogyne set up, or you have a physical therapist that you work with, because it's almost impossible if you don't have set up for this, for you to have all this available to it. The bladder training, it's okay. That can be done if you can make the patient do it. So the urinary, push it by 15 minutes each time and see how much you can do it. Because otherwise, if you go to the bathroom, it's that moment of urge that you need to go to the bathroom. If you can postpone it by 15 minutes each time, and said, how can you do that? Well, they give you some ideas here. I don't know. Distract your mind. Count backwards from 100. I'm sure that's going to work. Shift your position. That's, actually, it does. Quick, this is the squeeze, actually, probably is the best that I tell you. So see if you try to squeeze and, let it go, squeeze and let it go. And try to cross your legs and sit on a hard surface. So this is from the, actually the AUGS website. And if you be able to work with the patient, but this is what comes the difference with the patient being motivated. I mean, just really has to be motivated to do it. Medical treatment. So you try your behavior, you tried your caffeine, you know, we go with the SUFU guidelines, but now I have to add, you know, pharmacological therapy. Mostly the pharmacological therapy is for, you know, overactive bladder or urge incontinence. The mainstay of this is the antimuscarinic agents, M2, M3. What they do, remember the picture of the detrusor, inhibit the contractions. Can be prescribed, you know, typically I prescribe other behavior. You know, that's why you have the guidelines, right? The behavior first and, you know, medications. And it's an issue. I said, well, why? Because the effect is modest. So it's not a wonder drug. It's just not a wonder drug. So what they have a significant discontinuation because of side effects. So not only that doesn't work too well, but also have side effects. So that's the issue comes of getting the patient engaged from the beginning, from the perspective is, can you avoid this? You know, you explain them, so listen, the options are not, you know, so great, so we have to work together for this. And this is the list. And there, you know, we have the Detrol, what I use. You can start with you know, smaller doses and increase it, you know, by 2 weeks or so. 6 to 8 weeks, you should really start seeing, you know, improvement if he works. You know, I continue them even if it's moderate improvement up to 3 months. They're different ways. They're tablets, they're long-acting, they're gels nowadays, and so on. But these are the dosage that we have for the antimuscarinic therapy. So obviously, there are issues with that. Remember we discussed the modest improvement and discontinuation to the side effects, or we have some contraindication. I mean, gastric retention, untreated narrow angle closure glaucoma, supraventricular tachycardia. It's interesting that, you know, might be associated with worsening of with increased rates of Alzheimer's dementia. I mean, the antimuscarinic agent. And then you have the peripheral events. You have more of a central, you have more of a peripheral. Dry mouth, this is one of my problem, constipation, probably less tachycardia and palpitation. The problem starts if you have a patient in multiple type of medication. You really have to look through their list to make sure that additive effect to anticholinergic effect. Muscle relaxant, the tricyclics, antipsychotic, antihistaminics. Be a little careful. Usually don't see too much. So one issue, I'm going to start someone on a pill. You don't have too much of urinary retention, but doesn't mean doesn't exist. So you have to, when you start the patient, you say, listen, I do more family physician. It comes to me, I think she has stress urinary, you know, she has urge incontinence. I did a workup, I did a behavior, put on some medication. So, you know, sometimes complaints can avoid, even though it's unlikely, is small. Just be aware of it. And be aware of that if especially the combination with other type of anticholinergic, you know, medication. Then the miracle drug, you know, not, you know, so we have the antimuscarinic for the M2, and they're going to have the B3 adrenergic receptor. This is something a little bit not so new anymore. Creates the muscle relaxation. It's pretty good. Actually, we have a poster outside of it. It works better. You know, we have, you know, side effects like every other medication, but we have, you're really careful, you know, it's an issue of hypertension with the MIRA background. And it's interesting that you have the placebo. They have like a, you know, like 600 patients in a trial. The placebo is 8% high blood pressure. You know, for the, you know, was 25%. For 25 milligrams was like 14%, and with 50 milligrams was 8%. So I'm not so sure exactly what the issue is. Maybe already you don't usually start at 25. So I'm increasing by the time they got to 50. You kind of self-selected as the patient population. But high blood pressure, it's an issue. You know, people discontinue the lesser side effects, so people have the likelihood for them to keep them much longer. You have the discontinuation rate, you know, just, you know, no continuation around 60, 70% versus 20, 30% with antimuscarinic. And works a little bit better, similar to better. So you have some improvement in the outcomes, the lesser side effects, people keep them a little bit longer. You can, if you insure a space for it, it's great. Just be aware of, high blood pressure. So that's a drug that you can use, reasonable success. Then you're gonna go, something that is becoming a little bit more, Botox. That's something that we do not do on the regular basis. Most of us is done with a cystoscopy. You inject in the detrusor muscle. What you do, be careful about urinary retention, incomplete bladder, empty. Obviously, you do a cyst or you can get UTIs, but it's a reasonable option. So to put it all together, in 2012, I have AHRQ review. So they're looking at this treatment of overacting, urge incontinence, and overall incontinence. And then they had in 2017 another update. So they divided in non-pharmacological, I just want to put it all together, pharmacological intervention. And obviously health education. You have lifestyle changes. You have weight loss. Then you have this bladder training, slash biofeedback. You have the pelvic floor therapy. And then you can do a straight Kegel exercises, you can do vaginal colds, you can do weights, you can do impressa. Then you have therapeutic PESSARY. So they're just variation to what you do. I mean, obviously, I just wanted to mention here that that's more of a urogynecologist setup or urologist setup for you to do the tibial nerve stimulation, sacral neuromodulation. We're looking about right now the intravaginal electrical stimulation, magnetic stimulation. This is some newer, but this is done by urogynecologists or urologists specialized in women's health. Urethral plugs, not so much, not very used, in the urethral bulking. So you have, we discuss about all this intervention. This is the review. So that's what you have to take a look and said, what I like to do, I can do in my office. Pharmacological intervention, of course, if it's a postmenopausal patient, you can put them on estrogen, especially they have other, GSM symptoms. Mostly we use topical. We discuss about antimuscarinic, quite long. And they added a little bit, with some data regarding the calcium channel blockers. We discussed about Botox. Because Botox is becoming a little more mainstream than was, no original 2012 and 2015. It's, I think came out as recommended was part of standard versus just can be tried. Some data regarding the antidepressants. And these are the new things that are becoming more standard, and obviously the beta 3 adenoreceptor agonist. Obviously, you can do combination of things, and then you can use a little bit of chili pepper, or also apparently works. So these are the one in a nutshell what we discussed: urinary incontinence, you have the stress, you have the urge. An overactive bladder, and you have a mixed. The mixed could be more of urge and could be more of a stress. You can have a non-pharmacological intervention for the stress. Don't think necessarily needs to have surgery. You put them to lose weight, watch out for what they're eating, do their pelvic floor. Just you can put a PESSARY if you're interested. You can get some vaginal cone for physical therapy. You can put an impressa, so there are variation of things that can be done, depends what you choose to do. Obviously, do not forget to counsel the patient that, listen, we have 90% 1 year success if you have mild to moderate, moderate to severe stress urinary incontinence by using a sling. Sling, and that's the other thing, is the sling is different than the mesh that you use for anterior-posterior repair, and is not part of the FDA warning, and people have to kind of differentiate. There are complications, there are surgical complications, but generally speaking, there's like a low-risk complication, so there's something that doesn't mean you cannot refer people to have surgery. With the caveat, it's just never very simple. It's always some pelvic organ prolapse involved, so it might require a little bit larger surgery. It might come to you just for the urinary symptoms, you evaluate, maybe you don't appreciate this, but it's a combination of this. The unlikely setup that to go to someone that does just the pelvic organ prolapse or get the hysterectomy comes back and she hasn't been evaluated for urinary, you might find occult stress urinary incontinence that now it's your problem, so you have to kind of send them back. Regarding the pharmacological treatment, you know what? Start with the easy. You know, obviously postmenopausal requires some estrogen. Try it. Works okay. But it's not, you know, this is standard therapy, antimuscarinics. You know, you can use the beta 3 adenoreceptor agonist. Botox is getting there, but that's something that's already you started to send out. So you already started to send out at, you know, this level. I mean, antidepressants, and I don't have enough data this time to say, well, you should put everybody on calcium channel blocker or on, you know, SSRIs or tricyclics regarding this. You need a urogynecologist or a urologist for us to do the sacral modulation or the rest of intravaginal therapy, acupuncture, it's a lot of other things. But physical therapy in a pelvic floor therapy, it's available. So that's the overarching discussion. I think was tried to be more in a bladder basic rather than this very large, you know, 3-year fellowship type of discussion. Can be done in a primary care physician. There are a lot of variation that you can do. You shouldn't be afraid. You might just make the choice, I just want to screen and send, and that's fine also. I want to screen and treat a little bit, that's fine also. You just have to see. But I have to tell you, you just have to make sure before opening your discussion to have incontinence because they have it. So the issue is just be prepared what you ask for and just gonna give them opportunity. And once more, go to that AUGS, you know, and just print it out and just put it, you know, nice, beautiful color and put it in your office, and that's gonna really give a lot of information to the patient, and nicely done, very easy to understand. These are my references, and thank you.